Hello, everyone. I'm going to give a couple minutes to let all of you come through the virtual door to this beautiful virtual auditorium where we're going to have a very special event. And the numbers are going up fast. No pushing, no shoving. We're at 200 and moving still. So I want to make sure everybody gets in. And there is some limitation. We're at 219. It looks like 220 right there. We'll go ahead and get started. Good afternoon, everyone. I'm Rick Page. I'm Dean of the Larner College of Medicine, and I'm so pleased to welcome you today to the 7th annual Vito Imbasciani, PhD, MD, 85, and George DiSalvo LGBTQ Health Equity Lecture. Let me begin by expressing on behalf of the college my gratitude to Dr. Vito Imbasciani and his husband, George DiSalvo. It's through their generosity that we're here today, expanding our knowledge and understanding of the important issues in healthcare related to the LGBTQ community. To our knowledge, this is the only endowed lecture dedicated to LGBTQ healthcare at any medical school in the United States, and we continue to be proud to further the goals of health equity by shining a light on the specific needs of the LGBTQ community. We're very pleased to have Dr. Imbasciani with us today. We have the added and even rarer pleasure of welcoming Mr. George DiSalvo to this lecture, coming all the way from Southern California. Mr. DiSalvo took his undergraduate and MBA degrees at the University of Southern California, and for the past 20 years, he's served as a CFO for Kaiser Foundation Hospitals and Health Plan for Southern California. I know how busy a job that must be, especially during this pandemic. We're so pleased that, frankly, one of the silver linings of Zoom technology is that it's inclusive and it helps bring people together from throughout the country and throughout the world. I not only want to thank Dr. Imbasciani and Mr. DiSalvo for this generous gift, but I also must congratulate Dr. Imbasciani as the winner of this year's Alumni Award for Service to Community and Medicine, as he celebrates his 35th year reunion as a graduate of our College of Medicine. Thank you and congratulations, Dr. Imbasciani. Please now share some of your words with our audience.
Hi, everyone. Thank you, Dean Page, for those really gracious remarks. And I want to thank the students of all years at the Larner College of Medicine for their attendance at this lecture today. And I want to express admiration to the College of Medicine for their solid commitment to broadening diversity of all kinds at the college. This interest in diversity, on my part, started in 1982. I was a second-year medical student. I was elected by my classmates to the Committee on Advancement. And one day I walked into the office of the then dean, David Tormey, and I asked him, why is this School of Medicine so white? And that was an important question in and of itself, but it was also a surrogate for the other question, which I didn't feel comfortable asking. How is it that I feel like I'm the only gay medical student, male, in the entire College of Medicine? As it turns out, I wasn't, but I didn't know that until my 10th reunion, which speaks to the pernicious and constraining force that closets had on us all back in the 80s. And so here we are in the year 2020, socially distanced on Zoom, but not closeted anymore. And from where I stand, the class of 2021, 2022, 23, and 24, they look a lot different from the class of 1985. So in a moment, we're going to welcome Dr. Follin today as the 7th speaker in this lecture series, which is still unique, this annual lecture, the aim of which is to help all of you students and faculty better serve all of the communities in which they live and serve. in all their wonderful diversity. Each of us comes from a particular background, ethnically, socially, our religion, and our sexual identity and preference. But we're called upon as physicians and as healthcare administrators running hospitals to serve wildly diverse populations. And I really hope that this lectureship has in some small way enabled the students at the Larner College of Medicine to have a leg up on all of that. So thank you very much for this opportunity. Thanks, Dean.
Thank you so much, Dr. Imbasciani and Mr. DiSalvo. And from a personal standpoint, I remember meeting you, Vito, my first week here, which is exactly 2 years ago, and had the pleasure of getting to know George as well, and look forward to seeing you both in person on one coast or another with my wife, Jeannie, sometime soon. Now, this year's speaker is Dr. Lourdes Dolores Follins. Dr. Follins is a psychotherapist, curriculum developer, and behavioral science researcher. She provides direct clinical service, as well as training and consultation to nonprofit organizations. For years, Dr. Follins has been writing about healthcare and resilience in the Black LGBTQI community. I'm pleased to welcome Dr. Follins to the Larner College of Medicine, and I look forward to hearing what she will share with us. To introduce Dr. Follins and to lead the rest of today's program, I will now turn things over to Dr. Margaret Tando. Dr. Tando serves as the Associate Dean for Diversity, Equity, and Inclusion at the Larner College of Medicine. Even more exciting, she is a newly invested Richard L. Gamelli, MD, 74, Green and Gold Professor of Surgery. Please join me in welcoming Dr. Tando.
Thank you. Thank you very much, Dean Page, and thank you all for being here. Let me start by thanking our selection committee. They've done an incredible job, and I'm very excited to hear from Dr. Follins today. Today, we have the pleasure of hearing from Dr. Lourdes Follins. Dr. Follins introduces herself on her webpage with the following: I am a Black queer woman who is a first-generation college and graduate school graduate. I come from a long line of working-class survivors and intrepid women, and am inspired by my ancestors' experiences and courage. She speaks to us today from New York City, where she has an ongoing psychotherapy practice which focuses on the needs of LGBTQ patients of color. Dr. Follins is the author of Black LGBT Health in the United States, The Intersection of Race, Gender, and Sexual Orientation, which was published in 2016 and is considered the text on the psychological care of LGBTQ patients of color. She's also the lead author on scholarly publications which describe resilience in Black LGBTQ persons, the creation of faculty interest groups for historically underrepresented faculty, and the development of behavioral HIV prevention interventions for Black gay men. Dr. Follins speaks to us today from her 21 years of experience in the field and as a national leader in the health of LGBTQ people of color. We look forward to learning from that experience as she tells us more about an intersectional approach to LGBTQI healthcare. I now invite our audience, I will invite our audience members to use the Q&A answer box at the bottom of their screen to submit questions for Dr. Follins. We will take questions at the end of the lecture. Please now help me in welcoming Dr. Lourdes Dolores Follins to present the 7th annual Vito Imbasciani George DiSalvo LGBTQ Health Equity Lecture. Dr. Follins.
Good evening, everyone. I wish we were in front of each other, because what I usually do when I'm with the crowd is I say good evening, And I usually hope that the crowd says something back to me, because hearing your voices gives me even more energy than I already have. Unfortunately, though, your mics are muted. So I'm not going to hear from the 287 people that are joining us today, but perhaps another time. So thank you for giving us your time. I'm going to share a PowerPoint presentation with you, and I'm going to take it from here. I'm going to share my screen in a second. Share screen, PowerPoint, share. No, not that. Okay. All right. So can you see the slides? Dr. Upton, thank you, wonderful. So this talk is called An Intersectional Approach to LGBTQI Healthcare in the United States. And I wanna just start off by saying that I titled it this because I think it's important that we take an intersectional approach to LGBTQI healthcare. More often than not, that's not necessarily the approach that everyone takes, okay? So here's the agenda. I'm going to go over some definitions to make sure that we're all on the same page, talk about intersectionality and healthcare, and then I'll talk about LGBTQI patients' relationships to the healthcare system, health disparities that are experienced by LGBTQI communities pre-COVID-19, and then I'll describe some additional concerns facing LGBTQI communities both pre and during COVID. And then I'll describe patients' resilience and resistance, because I don't take the pathologizing approach. I always look at people's strengths as well as their risks. And then I make some suggestions about what you as providers can do. And then I just wrap it up with some key points, and then we'll go into questions and answers, okay? Ordinarily, if we were in person, I would ask folks, or to give you opportunity to make, ask some questions during my talk, but just because this is a different setting, I'm gonna ask you to hold your questions, but luckily you can write them down so you won't forget anything. So first I need to acknowledge Dr. Kimberly Crenshaw, the originator of the term intersectionality. She created this term to describe the legal predicament of Black women because of their race and because of their gender, or particularly because of racism and sexism. And so now it's a term that we use in so many different fields, right? But I also want to thank the Imbasciani DiSalvo Lectureship Endowed Fund, the Selection Committee, and Dr. Michael D. Upton. So I want to start off with this moment of reflection. I'd like you to really stop and, hold on, something's happening. There we go. Ooh. Take a moment to reflect on why you decided to become a doctor. Just think about it. And it could be one reason, it could be multiple reasons, but just think about why you decided to become a doctor. Why are you in med school? I'd like you to keep those reasons in the forefront of your mind as you listen to my talk tonight, okay? So for this talk, this is the definition that I'm using of intersectionality. It's an approach that recognizes that identities are not isolated, nor are they additive. So in other words, you're not adding the race of the person, the sex of the person, the class of the person. No. They're interrelated and they're mutually constitutive. And so we're referencing the work of Dr. Lisa Boleg, a psychologist who I believe is on the East Coast. By using this framework, providers are better able to understand the complexity of the multiple factors that contribute to mental and physical health issues and enhance the well-being of LGBTQI communities. And what I'm citing here is the definition that I used in a recent chapter in a book printed out by Oxford University Press. And it's important for us to remember that while most definitions of intersectionality focus on the person with their identities, for example, focus on the race of the person, the gender of the person, the sexuality of the person, Dr. Crenshaw was focused on the power structures. The power structures that cause literal and figurative harm to people. So she was looking at racism. She was looking at sexism. And then we can also add to that heterosexism, cisgenderism, Islamophobia, homophobia, transphobia, biphobia. And so I want to challenge us to remember it's not just about the identities, but it's really about the power structures that are reacting to individuals' identities, that are reacting to communities' identities, okay? And so the next definition I want to offer is intersex, because you notice, or many of you probably noticed, this is a talk about LGBTQI. And more often than not, at least in my experience, you know, we write LGBTQI, but there's very little actually mentioned about intersex communities or people with intersex conditions. And so to me, it's important to make sure that, one, they're represented as well, but then also I want to use a definition so that we're all clear about what we're talking about. So intersex is an umbrella term. So it's not one thing. We're talking about an umbrella term used to describe a wide range of completely natural bodily variations. Intersex people are born with sex characteristics, which includes genitals, gonads, and chromosome patterns that do not fit typical binary notions of male or female bodies. And so the little flag that you see off to the left, this is an intersex pride flag, okay? But a note about wording. Now, during your clinical practice, you might hear a variety of terms used to refer to intersex people. You might hear the term intersex people, you might hear intersex, you might hear people with intersex conditions or people with intersex traits. You also might hear a term, differences of sexual development. And so you'll hear different people using the same term to refer to the same communities, give or take. But then also you might meet in your work, in your personal lives, you might meet intersex people who amongst themselves use different terms to refer to themselves. So some people with particular conditions that are typically under the umbrella of intersex might say, no, 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 I don't have intersex. I've got CAH. I've got something else. I'm different. Or I've got CIS. I'm different. I'm not intersex. And so I just want to make you aware of the fact that there are conversations around words and who gets to name who, and which words and which titles are claimed, okay? Another definition I want to offer is resilience. And so simply we're talking about people or communities being exposed to significant threat or severe adversity, but also the achievement of positive adaptation to the diversity despite these threats. And it's important, or I thought it was important to raise the issue of resilience because much of the medical and the social science literature takes a pathologizing approach and solely focuses on the adversity, the trauma, and the stress faced by LGBTQI communities. If we remember the resilience of these communities, as well as those of non-LGBTQI people, it's important because it adds nuance to people's realities and their lived experiences, but also remembering LGBTQI patients and all patients' resilience, it suggests paths for effective interventions and solutions. And so if you remember the fact that, okay, so my clients might have had to experience an arduous process just to get into the door, or an arduous process just to get to the building, but they still got here. That's a sign of resilience. And you can use that in your work, in your collaboration with your patients. And so the last definition I want to offer you is resistance. And Oxford Dictionary gave me a lovely, succinct definition: the refusal to accept or comply with something, the attempt to prevent something by action or by argument. And I think it's important to raise the issue of resistance in the context of healthcare because too often providers complain about patients' non-compliance. You notice I'm doing the air quotes, non-compliance, without exploring why patients are refusing to do as you ask. We usually just think, oh, I went out of my way, I came up with this approach, and you're rejecting it, or you're not doing what I suggested that you do, but I know what you should be doing. This is the right thing. Well, resistance is how humans demonstrate agency. This is how we show that we have power. And having that resistance, especially in the context where you might feel powerless, is very important, and very important for providers to look out for. So instead of lamenting about patients' non-compliance, think about what you've asked of them, or think about what you've told them, and the possibility that what you might have ordered, whether it's a test, whether it's a medication, whether it's a procedure, is actually detrimental to that person's mental health, their physical health, their financial health, and or their spiritual well-being. So for example, if taking pills does not fit in with the patient's sense of themselves as a healthy person or as a carefree person, why would they take the pills? Or they would have to find a way to intellectually or cognitively find a way to incorporate that behavior into their sense of self. Otherwise, this thing that you're offering them or you're telling them is in their best interest might be too threatening, either physically threatening or threatening to their sense of self. And if you're working with a patient who disagrees with you on a very basic level about what's in their best interest, and you don't find a way to work with the resistance, you're going to lose a patient, or they're not going to do what you're asking them to do, okay? So these are the 4 definitions that I'm offering, because these are words that I'm using throughout this talk. And I want to make sure that we're all on the same page about what I mean, all right? And so intersectionality, the reason why I'm talking about intersectionality is because, as we know, our core identity as people are composed of a variety of social statuses. So we've got your ethno-racial identity, you've got gender, you've got sexual orientation, social economic status, education level, religious identity, if any, and any other significant parts of themselves, which also includes ability. And so these social statuses frame their experiences of the world. They frame how they see things, but they also frame how people interact with them. And so the intersectionality of racism, sexism, heterosexism, homophobia, biphobia, transphobia, all of these things combine to greatly impact, to negatively impact the experiences of LGBTQI people. And these multiple social statuses not only exist at the same time, but they also impact patterns of privilege and disadvantage. And in a minute, I'm going to give you an example of what that looks like, what these patterns of privilege and disadvantage look like. And so if you think about yourself and the people that you know or love or work with, we all operate and function within different contexts throughout the day, throughout the month, throughout our lives. And so when I'm talking about context, I mean settings, right? And so I'll use myself. So I have varying degrees of privilege and advantage in different settings. So for example, in this setting, here with you, I am a scholar, I'm a therapist, I'm someone who's seen as an expert, which I have to say was very touching to hear. It's like, oh, that's how you see me. But in this setting, I'm someone who has privilege, I'm someone who has advantage, right? What you don't know about me is that, and I told some of the staff and faculty who work at the college, my mother was a licensed practical nurse. And so that for me is a privilege, because my mother, who was also a cardiac patient, she had this perspective that medical providers are supposed to be part of your team. She never had this idea as a Black woman that medical providers knew more than her, medical providers could tell her what to do, or medical providers would strong arm her into doing things that she might not think were in her best interest. And so my mother introduced me to this perspective. And so whenever I interact with anyone in the healthcare system, I have that level of entitlement because my mother taught me. Also, my father was the chief of maintenance of a medical clinic. So I grew up interacting with nurses and doctors and sometimes calling them, by nicknames or not really their first name, because we're Black people, we didn't do that. We're a particular class of Black people, we didn't do that. But I was on a very comfortable, friendly, we had rapport. And so there was never this hierarchy, except by age, but there was never this hierarchy of, well, you're a doctor, I can't talk to you. So here I am, that's also a privilege. Most of your patients don't have this. Most of your patients don't come from backgrounds where people have this belief that medical providers are supposed to be part of their team, okay? And so here I am, a middle class, middle-aged, Black, queer woman who's also a priest of a West African religion with a master's degree and a PhD. So all of this together, depending on the context, changes my privilege and my advantages. So in this setting, I've got lots of privilege, but in my neighborhood, I live in a historically white neighborhood that is middle class and upper class. And so when I walk out in the street, people don't know I have a PhD. They don't know I'm a priest. They might not even recognize that I'm middle-aged. They might just see a little Black woman. And so in this neighborhood, that is not a privilege. That's a disadvantage. That is definitely a disadvantage. But then in my workplace, I work for myself. And my clients, by and large, choose me because of who I am, but they also choose me because of what I do. And so that's also a privilege. But then when I go to the doctor's office, now I'm in relatively good health, but they don't know I'm a doctor. Or better yet, they don't know I have a PhD. They might not even know I have a master's degree. All they see is middle-aged Black woman. And so then when they offer me a pregnancy test, I'll say, oh no, I don't need that. Let's say, well, you have to take it. No, I don't need that. Well, you have to take it. This is part of our protocol. Well, I don't have sex with men. Well, you have to take it. It's part of our protocol. And so this was a constant conversation, and I'm saying conversation in air quotes, that I experienced before I experienced perimenopause. And when I didn't tell the medical providers, both the nurses, the nursing assistants, or the doctor, I have a PhD, I'm a clinical social worker. My mother was a nurse. I know what I'm talking about. If I don't share these things, I get treated as if I know nothing. I get treated as if I don't know anything about my body or what is good for me. But if I out myself as a person with multiple degrees and who also happens to be a therapist, oh, I get treated very, very different. There's some deference. There's some interest in me then. Then I'm an interesting person. I'm not just a patient, I'm an interesting person. And so this is stressful because if I'm sitting in a medical provider's office, I'm there to get something. I'm there because I need something. I'm not there because I just want to, chat. I'm there because I'm in need of some care. And so to face this, and this is me as someone who comes from a family where medical providers are seen as your teammates, I have that advantage. And even I who have that advantage have to come out as someone with privilege to get good care. So when we talk about LGBTQI patients' relationship to the healthcare system, it's mixed. Because there's the issue of, well, which parts of us are seen? Literally, what do providers actually see? And it's not just providers, it is the person who works at the front desk. What are they actually seeing? Before they see any paperwork, what are they seeing? Nurses, what are they seeing? Medical providers, as far as the doctors or the physician assistants, what do they see? Or the nurse practitioners, what do they see? And then how are those parts of us interacted with? So if there's a preconceived idea that, oh, she's a Black person, or oh, they're Asian, or oh, they're from the Middle East. Oh, if there are, whether it's implicit bias or outright stereotyping, that may impact how people are responding to these patients. And then who is doing the interaction? And so this has been a really fascinating week for me because it's Thursday and I've been seeing clients since Monday. And in 4 days, I've had at least 3 or 4 conversations with clients about the healthcare system and their experience with the healthcare system. Now, 92% of my clients are lesbian or gay or bi or queer or pansexual. And so I'm constantly talking with people about how their sexuality and gender identity and their ethno-racial background are being addressed. And so I want to share with you a patient. So what I'm going to share with you is what happened, AKA what went wrong. And then I'm going to share with you what could have gone, like how things could have gone better. So this is a 35-year-old queer identified Chicana who came to the clinic or went to the clinic to get a prescription for Cymbalta because she has fibromyalgia. On the intake form, she reported experiencing aches and pains in her body. And so my client told me that, again, like I said, she went into the clinic to get a prescription. She had moved from one part of the state to the other part of the state. And so she was going to a new state where they didn't know her, or sorry, not a new state, a new part of the state where they didn't know her. And so they had no information about her except what she wrote on the forms. And so she fills out the forms, and when it asks questions in the COVID screening about aches and pains, she ticks the boxes because she does have aches and pains. And actually, she's actually having difficulty standing upright because she's shaking, and her hands are also shaking. And these are symptoms of her fibromyalgia because she's been under a lot of stress, and it's a fibro, as she calls it, a fibro flare. And she ticked off these things on the form, handed them back to the receptionist, and pretty soon after she sat down, a white woman who was a nurse came over to her and said, "Do you have aches? Do you have pain? Do you have aches or pains?" As if my client was hearing impaired. My client's not hearing impaired. My client said, "I have aches and I have pains." And the nurse said, "Well, wait a minute. Do you have aches or do you have pains?" And so my client described her symptoms, and the nurse said, "Oh, well, you have aches." And this is a conversation happening in the waiting room. And so my client, the smart Alec, who went to Columbia University, looked at the nurse and said, "I'm sorry, I didn't go to medical school, so I haven't been trained in the difference between aches and pains." And she smiled because she was trying to just get through this because she was feeling awful. And she's having to contend with this person who's interacting with certain parts of her in a very aggressive and not helpful way. So then the nurse looked at her and said, "Fine." And my client said, "Well, I have fibro. That's why I have these symptoms." And the nurse said, "Fine, okay. You'll be seen soon." And walked away and left my client there. So my client's trying to compose herself. So then she called the person an orderly. I'm not sure what the person's title was, but this person took her from the waiting room and back to the exam room. And it was a young man who said, "Oh, so you have nerve pain?" My client was like, "Wait, I didn't say I have nerve pain. I have fibromyalgia." And the person said, "Well, this says here that you have nerve pain." My client said, "No, I have fibromyalgia. I have aches. I'm having tremors. It's hard to stand up." And this person said, "All right, fine. Well, the doctor will be here soon." Well, luckily for my client, the doctor came in, and as she reports, the exchange with the doctor was the best part of the visit. The doctor listened, the doctor asked questions, but not in a way that she didn't feel heard. The doctor seemed genuinely concerned and said, "Oh, okay," and wrote her a prescription for Cymbalta. So when I asked my client, after the two of us both, we both groaned like, "Oh my gosh, I can't believe this actually happened to you, and I'm so sorry." I said, "Well, what would you have preferred that happened?" And she said, "Well, first of all, it would have been wonderful if the nurse had just asked me, what are my symptoms? And, oh, I notice you have fibro. Are the aches and pains related to your fibro?" If the nurse had just trusted me to know my body, it wouldn't have been so stressful. It wouldn't have been so difficult. Because of the way she spoke to me, I wanted to leave. But I kept thinking, I need this prescription, so I will get through this. And so this is what you don't want patients to feel. You don't want them to feel like, I'm getting through this, especially because whether they're LGBTQI or not, you have no idea what trauma your patients have experienced before they get to you. And given what we know about trauma and the prevalence in this world and in this country, most of the people that you encounter, most of your patients, will have experienced some kind of trauma. And then when we talk about LGBTQI people, regardless of their ethno-racial background, they've probably experienced even more trauma. And so you want to be mindful of thinking about, okay, how do I talk to my patients when they're in need? Do I want to activate them or trigger them and then have them think I'm someone else who's trying to harm them? Or do I want them to see me as someone who's an ally in care? Okay. And so you want to be mindful of this. So you want to be mindful of, are people coming in with trauma? Are people coming in with trauma histories? So you want to be trauma sensitive or trauma aware or trauma informed. You also want to be mindful of the health disparities that LGBTQI people experienced before this pandemic or this pre-COVID-19 pandemic. So chronic stressors such as identity concealment, so hiding your identity or covering your identity. So covering is when you're not quite hiding it, but you're not telling anyone, and you're also not denying it, okay? But that's a different level of stress. So chronic stressors such as identity concealment or covering, discrimination and oppression, these can lead to both mental illness and substance use, and ultimately, to chronic medical disease. And so when we're talking about LGBTQI people and the health disparities that they experienced before COVID-19, these are largely the result of chronic stress from oppression, structural stigma, discrimination, and interpersonal as well as state-sponsored physical violence. There's also variation based on people's ethno-racial background. So for example, my wife, who's a white Jewish woman, what she experiences and what I experience, significantly different. As a white butch lesbian, she's got experiences around gender that I don't have as a femme woman. But as a Black woman, there are certain psychological stressors that I experience that she is completely oblivious to because she's not a Black person. And so it's important to remember that these health disparities, there's variation based on ethno-racial background, geographic locations, we're talking like where in the country, as well as we're talking about urban, suburban, or rural, class as well, and ability. And then sadly, there's very little research on the medical needs of intersex people besides surgery. So some of this applies neatly and some of this doesn't apply so well. But when we're talking about psychological distress and mental challenges, this is not about LGBTQI people being especially prone to these issues, but it's because when you live a life where you are literally under siege or you feel like you are under siege, or you're concerned often about being discriminated against or being invisible or being erased or being too visible and people having a negative reaction to that, that can cause distress and it can cause anxiety and depression. So even though, I forgot how many years it's been, but LGBTQI people, we can get married, but at the same time, we can still be harassed at school, harassed in our neighborhoods, harassed at work, we can be fired, we can lose housing or lose out on housing, we can't adopt or foster children in many states, or if not most states. And also, we're more likely to be randomly stopped by the police for violating gender norms. And I'm not saying every LGBTQI person, but those of us for whom our gender expression does not match what society thinks is appropriate or society is comfortable with, hence being stopped more randomly by police officers, which is distressing in and of itself. There's also substance use and misuse, including tobacco. And this is partially to cope with the oppression, stigma, and harm caused by societal exchanges or interactions, but also historically in this country and many other countries, But in this country, historically, when LGBTQ people would go meet, we had to meet in bars. And this was a time when, you could drink and smoke in a bar. And so if you've become accustomed or socialized to hanging out in a bar and smoking, it becomes habitual because smoking and drinking become associated with good times and connection. And so now that I think almost all across the country, you can't smoke in bars anymore. Okay, well, people are still smoking. There's now smoking outside, or people are still drinking. And so if you're either trying to self-medicate to cope with oppression and stigma, it's going to lead to, or it can lead to, misuse in ways that are at higher rates than people who aren't LGBTQ or I. And then we've got chronic health conditions, or being more likely to develop chronic health conditions. And particularly, we're talking about cardiovascular disease because of the chronic stress and the structural stigma. So if you think about being worried for your, if not your life or your livelihood, that means you're constantly on alert, you're constantly on edge. Or if you're not constantly thinking about it, so for example, some of my white gay male friends, they're not thinking about experiencing racism, but they are thinking about gay bashing at certain times of night. And these are, middle-class, middle-aged men. Or if they're going to, like, let's say we're going out to eat pre-COVID, they'd have to think really clearly about, okay, what are they wearing? What are they saying? Who are they talking with? How are they talking to people? And so thinking about these things that most people take for granted, don't think about, what you wear, how you move, how you dress, who you're with. These things can be very stressful and they take a toll. It's a slow but gradual toll that it takes. I joke with my wife, who's 4 years older than me, that I will die before her. And this is very distressing to her. She's like, don't say this, don't say this. I'm like, baby, statistically speaking, as a Black woman, my degrees will not protect me. My degrees will not protect me. But as a Black queer woman, there's a greater likelihood that I will not live longer than you. Partially because of the stress of anti-Blackness and misogynoir, okay? So there's cardiovascular disease. And then we've got cancers. And so cancers that we tend to find in, or more likely to find in LGBTQI communities, or at higher rates, I should be more specific, at higher rates, are lung cancer because of the historical connection to smoking, breast cancer because lesbians and trans men are less likely to be pregnant, which impacts, it's one of the risk factors for breast cancer. Ovarian cancer, again, because lesbians and trans men are less likely to get pap smears, or their medical providers will say, oh, well, you don't have sex with men, you don't need a pap smear. Like I've actually had partners who are either trans men or butch lesbians tell me they've had providers here in New York City say, oh, well, you've never had sex with a man. Oh, well, you don't need that. You don't need a pap smear. I'm not gonna waste my time. Or if we're also talking about some women, whether either, some women who are either butch and or masculine don't feel comfortable being penetrated, or they've experienced trauma, whether it's gynecological trauma or reproductive trauma or just trauma because it's, childhood sexual abuse or rape, that makes them less likely to see the gynecologist and get pap smears because it's a reminder of feeling vulnerable, feeling exposed. So those are just a few cancers that are part of the health disparity. And then we've got disordered eating among some gay men, bisexual men, and some other men who have sex with men. And again, this isn't everyone, but this is, for some who are seeking to fit an unrealistic body standard. I have lots of gay male friends, and one of the things that we talk about a lot, and I've known these guys for 20, 30 years, what I'm really clear about is even over the past 20, 30 years, there's still this pressure that they feel to look a certain way to be attractive, especially because we're talking about everybody wants to be desired. Everybody wants to be seen as attractive and appealing. And so that can lead to disordered eating, whether it's anorexia, whether it's bulimia, or whether it's excessive exercising in addition to restricting one's food intake or caloric intake. So there's that. And then lastly but not least, so there's HIV and other STIs. Unfortunately, gay, bisexual, and other men who have sex with men and trans people have higher rates of HIV than other populations, but it's because of the high rates of stigma, harassment, and discrimination. You know, if you're told that how you love and who you love is an abomination, or loving someone of the same gender is wrong or against God, or it's just wrong, period, you're going to be more secretive about how you love. You're going to also, and it also might be more challenging for you to take precautions to protect yourselves. In my research with young Black and Latino gay men, what they told me over and over again was, by and large, well, nobody loves me, so why should I protect myself? You know, gay means God aids you, right? And so, and these were young men. These were young men who were in their late teens to early 20s, who had heard the same trope that my older gay male peers had. And so HIV and STI rates, infection rates, are higher because sex is good for everybody, right? Voluntary sex feels good for everyone. And so in a world that says that you are wrong and how you love is wrong, sex might be one way to be redeemed. Sex might be one way to have a connection with someone. Sex might be another way to get affirmed for your beauty, your brilliance, your sexiness, for all the things that the world tells you is wrong with you, okay? And so additional concerns facing LGBTQI communities, again, there's lots of variation based on ethno-racial background, geographic location, ability, and class, but mental health concerns due to the COVID-19 pandemic, when we're talking about young people, so youth and emerging adults, so people under up to 25, there may be some pre-existing mental health concerns. So there may have already been some anxiety or some depression or just distress. And because we're being forced to shelter or because we're being forced to be physically distanced, these mental health concerns might be exacerbated. You might also see more disordered eating, if that wasn't there already, or some substance use and or misuse amongst these young people. And then we're talking about people over 50 who hardly ever get talked about. So LGBTQI people over 50, generally speaking, compared to non-LGBTQI populations, people over 50 that are LGBTQI might be more likely or tend to be more likely to be socially isolated if they're not partnered, if they don't have family, both of their own or of origin, or if they're not part of an LGBTQI community. And so, I've met with some of the folks that work at UVM College of Medicine, and some talked about being, lifelong Vermonters and growing up in rural areas. And so it made me think about, what's life like for an LGBTQI person in Vermont, for example, in rural Vermont? Like, what's that like? Especially if they're not partnered, or if they are partnered and their partner's not well. How is this pandemic impacting them? Especially since initially we were told, people over 50, you should stay home. You should stay home, you shouldn't go anywhere. Stay in your house, don't go anywhere, don't have anybody around. And so if you're an LGBTQI person and you don't have family, and or your partner, let's say your partner died, either because of COVID or for something else, you're alone. And that can be really, really distressing. I mean, I've got, most of my clients are millennials. And so I've got millennials who are lamenting about how alone that they feel. Imagine being over 50, where, there's this societal expectation, well, you're not going to go out, you're not going to go to the clubs. What are you going to do? How are you going to meet people? And so if you're having, if you have the chance to work with LGBTQI people over 50, you definitely want to check in with them about their mental health. And so you want to ask questions about things like, support, who supports you, who's in your support network, who do you turn to if you need advice, who do you turn to if you need, food, who do you turn to if you need help with something. You want to ask those questions, okay? And then when we're talking about financial concerns, pre-COVID, LGBTQI people were more likely to live in poverty and also more likely to lack access to adequate medical care and also more likely to not have health insurance. And so I'm always struck by how at Pride, the end of June, but in some places it's in October, depending on the where you are in the country. There are all these advertisements about the gay community, and they're usually images of middle class or upper middle class, mostly white gay men or white people, and they are not the typical LGBTQI person. So those images that you tend to see advertising Pride or advertising, I don't know, Smirnoff vodka or advertising things in different LGBTQI magazines or catalogs or what have you, or websites, those are not the typical LGBTQI people. Your typical average LGBTQI person might be poor or working class. And may not have access. And access can be, they physically can't get to it because because of the distance, or they don't have the means, like a car or money to get to a medical provider, or the medical providers in their area are not culturally humble or even working towards cultural competence. And so that's one thing. In addition, pre-COVID-19, intersex people who were operated on against their will, let's say as children, will have the additional expense for their life of hormone replacement therapy. So, and that's because what sometimes happens, more often than not, sadly, intersex infants or children, their primary caregivers give medical providers the permission to operate on them. And what that means is these infants or children's gonads are removed. And so, as we know, gonads are hormone producing organs. And so if you remove these organs, you then have this person who has to take hormones for the rest of their life. And this impacts the quality of life as well as their health and development. And so this is a financial stressor that doesn't have to exist, but I'm going to let you have a whole nother separate intersex workshop with somebody else. But this is pre-COVID-19, okay? And so here we are during the pandemic, additional financial concerns facing LGBTQI people is that we've got studies that show that LGBTQI people were more likely to be laid off and have hours reduced compared to their heterosexual peers during this pandemic. And then this is exacerbated or compounded for LGBTQI people of color who tend to be less financially secure than both other LGBTQI peers and heterosexual people, cisgender heterosexual people. And then also during the pandemic, when it comes to finances, LGBTQI college students might have had to return to their primary caregiver's home. And if they weren't out before they went to college, they might have to go back into the closet, which for those of us who are LGBTQI, we know is a really tiny, stressful place to be in. But that might be what they need. Or if they were out, but their primary caregivers were not supportive, then there's a level of stigma, whether it's heterosexism or homophobia or transphobia or cisgenderism, there's stigma that they're contending with, which is very, very stressful in the middle of a pandemic. Or if their primary caregivers were not supportive and were hostile, they might be facing violence right now. Or there might be a threat of violence. Or let's say they were living with a partner and pre-pandemic, there was some struggles, or the partner was distressed, or there was some borderline intimate partner violence. Well, as we know, or as we've been hearing during this pandemic, more people who've had experiences with intimate partner violence those numbers, those rates have increased. Okay, and so LGBTQI college students who are living in these conditions might be they might be in harm's way, right? Or they might become unhoused and homeless, right? And so when we're talking about mortality, there we go. COVID-19 mortality and race, Black people, Latinx people, and Asian Pacific Islander Americans are dying at higher rates of COVID. And so what we know is that most of the people who have died that are Black, Latinx, or APIA, most of those people, no one asked about their sexuality or their gender identity. And so I'd be willing to wager money, and I don't like to bet my money, that a number of those people, or a disproportionate number of those people, were LGBTQI. And so it's important to think about these things. I know it's a lot to think about, but your patients can help. And so despite these health disparities, LGBTQI patients demonstrate quite a lot of resilience. So the fact that they woke up, made it into your office, and survived in the face of adversity are all signs that they have hope for a better future. Some people say, what are you talking about? They just woke up. Anybody can wake up. Yes, that is true, but not everybody does. And then also, not everybody wakes up and chooses to stay awake. Some people wake up and say, oh my gosh, this is too hard. I don't want to do this anymore. But the fact that your patient came in to see you, to talk with you, they have some resilience. In addition, for those who have support networks or community, the fact that they've been able to develop and maintain relationships are also signs of resilience. Having a relationship with family, and this can be family of origin or family of choice, having partnerships, having friends, having other community members that you're in contact with, these are also signs of resilience. I mean, one of the things that has helped me survive are my friends. Yes, I've got partners, but my friends and the people in my religious community have helped me survive despite all the things that are in front of me. In addition, participation in community events. So some people are involved in house ball communities. So basically these are communities whereby usually Black and Latino or Latinx, where people compete as houses. And houses are basically kind of like what they sound like. It's you and a group of other people that get together, and what you share are either gender identity or sexual orientation or some combination, and they compete. Pose, the show Pose is a beautiful example of houseball communities. Being able to participate in those events, but also because you have a relationship, and the work that's involved in maintaining those relationships and then participating in these events shows signs of resilience. Pride events, protests, as well as political involvement. And political involvement can be electoral politics or other politics. It doesn't have to be just one thing. And also the fact that they're continuing to seek care despite the fear that they'll be discriminated against in your office. And again, it might not be about you. I mean, if it is about you, that's a whole other conversation. But it might not be about you. It could be that they've had previous experiences with medical providers that were so harmful or so heartbreaking or so damaging or so distressing that 1, 2, 15, 20, however many experiences made them say, yeah, I'm not going to get anything. I'm not going to do this. Like we know of people, LGBTQI people who have been harmed in public and who are very clearly saying, no, I'm not gonna, don't call the ambulance. Don't call because I don't want to deal with the hospital. I don't want to deal with the medical providers. I don't want to hear what they have to say, because there's an anticipation of harm, either literal harm, as in not being cared for, not being cared for properly, or carelessness, or harm with what's being said or what's not being said, or the kind of emotional care that's not provided, okay? But the fact that your LGBTQI patient showed up, even though they might have been afraid that you would discriminate against them, that is a sign of resilience. And then how they describe, or we demonstrate resistance. Being late for an appointment at an organization where you expect to be disrespected or marginalized shows that, okay, I'm here, but you can't tell me what to do. You don't control me. Also, refusing to take toxic medications. I mean, if we think about it, yes, there are a number of medications that providers prescribe, which are healthy. They're helpful, they're healthy, they're good for you. And then there are quite a few that are not good for you. They damage your kidney, they damage your liver, or the side effects are awful. And so some patients will say, no, I'm not taking that. No, I'm not taking those medications. They will make me sick. They make me feel terrible. And so instead, they might seek less harmful treatment options, whether it's something homeopathic, something herbal. So they might say, well, let me try something else. Let me try a lower dose. Let me try anything else. You might have patients crossing out words on intake forms or replacing words that exclude them. Also, asking you to call them by their preferred names and preferred pronouns is a way of resisting. And one last way, I mean, these are not all the ways, but these are just some ways. Refusing to answer to their dead name. And so for those of you who don't know, dead name is essentially a name that, so for example, it's the name that you're given at birth by the people who raised you. And it's called a dead name because it means that you no longer identify with or are called by that name because it doesn't suit you. It doesn't fit you. And so, for example, if the person is someone who is trans masculine identified, so someone assigned female at birth, but identifies as male, and you're calling for Patricia, but the person goes by Rocky, and Rocky doesn't respond when you call them Patricia, that's resistance. And so if Rocky waits until you say Rocky and then says, oh, okay, that's me, that's resistance. So the patient is not being disrespectful. The patient's very clear about, you're going to interact with me in a very particular way because I cannot tolerate being called something that doesn't feel right to me. So what can you do as a provider? There are quite a few things you can do. There are things that you can do to impact health disparities, but there are also things that you can do just in your work with LGBTQI patients. So I've actually read the oath that you take as part of your white coat ceremony. And so there's a part about not playing God or playing at God. And so one thing you can do is remember that not playing at God also means not imposing your worldview on your patient. So even though to you, medication is the best thing, it's always the best way, Western medication is the best in the world, for your patient, they may not think it's that, especially if either they don't come from the same world, like the world view, or the same culture as you. So for example, if I think about, I was talking with a Black woman, and actually I'm going to say African-American because her ancestors were part of the original enslaved Black people that landed in Virginia. And so this is a woman who has fibroids. It's a 30-year-old woman, 30-year-old African-American woman who has fibroids. And her fibroids are so large that it appears her uterus is the size of someone who is 3 months pregnant. And so this is my client who's got lots of symptoms and having fibroids this large and a uterus this large. And when the GYN said to her, okay, we'll take this medication, it'll shrink them, she first thought, okay, well, what are the side effects? And the provider told her, the doctor said, well, they're, listed all these negative things. And my client said, no, I'm going to try some herbal stuff first. Now, this is what works for her. It doesn't necessarily mean that she will not ever use the medication, but she wants to try something else first. So trying not to impose your worldview on the patient is vital. Also, identify and support your patient's resilience. literally say it out loud to them so they know that they're seen. As a therapist, I know how important it is to feel seen, to be seen, because I have clients say things like that to me, like, oh my God, I feel seen. I feel like you get me. And I'm like, okay, well, this is good. As a medical provider, you also want your clients to feel seen. Because if they don't feel seen, if they feel as if you're treating them like just another number, just another chart, just another case, you might lose that person, or they might become unwell or more unwell. Also, I encourage you to think about whether heterosexism, cisgenderism, or homonegativity have been barriers to care at your hospital or your clinic. Have these things gotten in the way of patients coming back or patients coming in? Okay. You also want to think about joining organizations that focus on LGBTQI health. So for example, there's an organization called GLAMA, which is the Health Professionals Advancing LGBTQ Equality. They have a conference every year. I think their last conference was like a week or two ago. It's always pretty phenomenal. And for medical providers, you can always get CEs, right? Yeah, CEs. Lots of really fascinating work, groundbreaking work, research, as well as what people are actually doing in their clinical work. So that's GLAMA. There's also an organization called Interact, and this is Advocates for Intersex Youth. They basically are an advocacy organization that are working, or that's working to stop genital surgeries on intersex youth. Because I don't know if you know, but by and large, it's changing, but not enough. There are still intersex infants and intersex children that are undergoing genital surgeries. And yes, genital surgeries. And so if you're talking about an infant who is being operated on, so let's say there's a vaginoplasty being performed on an infant or a young child, that's excruciating for that child to experience. This organization is fighting so that those surgeries no longer happen, or they no longer happen until children can consent or assent. Right now, the medical providers are just turning to the parents for that. And the last organization is that I'm offering you is WPATH. So it's the World Professional Association for Transgender Health. And it's an organization that works with people, it's, providers, mental health providers like myself, surgeons, urologists, a variety of people who work with trans people, non-binary people, as well as intersex people, and come up with best practices on how to support these different communities. So those are 4 things you can do, but there's more. Also, make sure there's an option for intersex, non-binary, and genderqueer people to check on your intake forms in the gender category. So if your intake forms simply say, what's your gender? Or they say, what's your sex? And you've only got male or female, you're leaving out a lot of people. And this is not about being politically correct. It's about making sure that you understand really who your patients are, but it's also a way of letting your patients know, oh, we welcome you. So an intersex person seeing intersex as an option, that alone might keep them in the room. I mean, I just heard about a study whereby 82% of intersex people that go for medical care, they don't return because of how they're treated. 82%. That is an absurdly high number. And then when we're talking about trans people, the numbers are lower, but still, these are, there's no need, especially when we can avoid creating conditions whereby people in need feel shunned or turned away. So something as little as having a box that asks about, or having areas that ask about assigned sex and gender identity, and then having options. Very simple, really doesn't take up a lot of space, totally feasible. And then also, if your hospital or clinic provides hormone replacement therapy for trans people, make it available for intersex people as well, because as I mentioned before, if they've had their gonads removed, they're going to need HRT for the rest of their lives. And so make it available. Way too many people that are intersex, especially adults, if they're going to a provider that They don't know. They're put in this condition or this situation of having to explain and then essentially ask for, for medication and then fight for it, which is unnecessary. It's absolutely unnecessary. Also, if this is a patient that you've seen before or someone else has seen before and they've been labeled as non-compliant, ask the patient from a place of curiosity rather than annoyance about their non-compliance. Don't just assume that, they're just difficult and they just want to be difficult. Ask, so I heard that you saw Dr. So-and-so, or I heard that you've been seen before and you were suggested, or you were advised to do X, Y, and Z. What happened? What got in the way of you following up with that? Is there anything we could have done? Do you need help accessing that? Do you need someone to liaise? So ask from a place of curiosity as opposed to annoyance. Also, don't assume that LGBTQI patients don't have reproductive desires or fertility concerns just because of who they are, or who they love, or who they have sex with. You might be surprised that there are trans men who want to be pregnant, or trans men who don't want to be pregnant, or trans women who want to co-create with a partner using sperm, or there might be a gay man who's like, okay, I've always wanted to have children and I want to find ways to create a child. So don't assume that because they're LGBTQ or I, that they don't have any interest in fertility, or they don't have any interest in giving birth or creating a life. And then the last set of things, again, this is not exhaustive. Treat them how you would treat a loved one, with care and respect. And I know, part of me, I feel really silly even saying this, but I recognize the fact that because of neoliberalism, because of capitalism, increasingly your time with patients is limited. And so you're often really harried, you're often really rushed, you often are just kind of like, come on, get on with it. I don't have a lot of time, because you don't have a lot of time. And still, for an LGBTQI patient, and honestly, any patient, treat them with care, treat them with respect, treat them the way you would want to treat your favorite person. Also remember that while you're more knowledgeable about science and matters of the body, your patient is the expert when it comes to their body. And I wrote here most SGM, so we're talking about sexual and gender minorities. Most sexual and gender minorities, which is another way of saying LGBTQI people, most people haven't had providers treat them as partners in their health. And so that goes back to what I was talking about before, about how my mother trained me to see medical providers as teammates. And if they're not good teammates, you get somebody else, you get another teammate. They're replaceable, that's what she would say. And so most of us, most LGBTQI patients, haven't had providers treat them as partners. We've had providers tell us, this is what you need to do, this is how you do, oh, you're not gonna do, okay, well, you can go find somebody else. You have an opportunity to do something different. You have an opportunity to create a different experience. Also, take a culturally humble approach. Lots of people talk about cultural competence. The problem I have with that term is cultural competence. It kind of assumes that you're walking down a path and there's an end. There's never an end. You will never know enough about your culture and other people's cultures. It's just not possible. And so if you take a culturally humble approach, so if you take an approach whereby you're really clear, like it says in your oath, I don't know. It's okay to say, I don't know. It's okay to say, tell me more about that. It also gets your client closer to you. It builds rapport, okay? And then the last thing I have here is ask questions about assigned sex versus gender identity, but also ask questions about their stressors. Because knowing what is stressing or distressing your LGBTQI patients will help you understand about compliance as well as their health, all right? Also ask about their support networks, because the support networks might be able to help with their stressors, and also ask about barriers to care. So barriers to care could be, how long did it take you to get here today? Okay, it took you 2 hours. Wow, okay. How'd you get here? Oh, you took a bus and then a bus and then a bus. Wow. How often do you do that? You know, knowing things like, do they have the means to get there, whether it's money or access to public transportation or a car, or can they borrow a car? Or are they sneaking out? If this is a young person whose primary caregivers don't know that they're LGBTQ, or right, that they don't know they're LGBTQ, they might be sneaking out to see you. That might be a barrier to care. Having to hide might be a barrier to care. So you want to ask about these things if you can. And so as I wrap up, a couple things I'd like to leave you with are, or just remind you of, is mainstream healthcare settings are often just one more setting in which LGBTQI patients are othered or invisibilized. Also, a colorblind, a sexuality blind, or a gender blind approach is detrimental to all patients, but especially to LGBTQI patients, because it discounts both the reality of their lives, like their lived experience. So the fact that my Chicana client, if the medical provider discounted the fact that she's Chicana, she wouldn't have understood, or they wouldn't have understood why my client was so offended when this white nurse spoke to her as if she didn't speak English. Okay, so taking this kind of, color blind or sexuality blind or gender blind approach disregards the lived experience of your patients, but also it discounts the circumstances that impact their health and their healthcare access. And also remember that your LGBTQI patients' resilience, like they have resilience, and look for the ways in which they resist oppression, both in the world and in your office or exam room. So be curious, in the way that you're curious in your classrooms, in your studies, be curious about them. But not like, because they're freakish, but be curious because you really want to understand who they are and what brought them to where they are. And the next time you're facing a person who's LGBTQI, or really any patient, remember the oath you took. Remember the oath that you took during your white coat ceremony, okay? So, questions and answers. I believe that this is time for questions and answers.
Thank you, Dr. Follins, for a very informative and thought-provoking lecture. We really appreciate your being here today. I'd like to take some time now to answer the questions. We've got some coming in. For those of you who have not posed your questions yet, please do so through the question and answer function, and I'll pose them to Dr. Follins, and we'll get through as many of them as we can. So Dr. Bonnie asks, Vermont is a small place. Do you have any advice for interaction outside the clinic in public spaces? You obviously don't want to disclose or violate privacy, but there are sometimes issues that are difficult and aren't discussed in the office that people want to talk to us about.
Mm-hmm. So that's a wonderful question. I think you heard me chuckle because I'm a member of the communities that I work in and work for. And so I'm always, to be facetious, I'm always kind of ducking and dodging, like, oh no, I see somebody, oh no, they might see me. But that's the nature of the work when you work in either small communities or communities that you're a part of. And so my suggestion is to actually in the office, acknowledge it. Like just say that, say, hey, so, just want to let you know, we live in a small town, we live in a community of X amount of people. There's a chance that you and I might encounter each other in the supermarket. Or there's a chance that I might know your cousin Bob, or you might know my Aunt Tilly. And so I just want to let you know that. And, I would encourage you, if there's time to talk about that, you don't have to have a long drawn out conversation, but if there's time to just say, okay, so I want to let you know about this, how do you feel about that? And how would you want to handle this? Because I want to let you know that I will never disclose anything that we talk about in the office out in public, but I'd like to know if we do encounter each other in public, how would you like to handle it? Because I want to take your lead. I would never just walk up to you, hey, how you doing? But let me know how you'd like to handle that. So it gives the agency back to the patient, but also it makes them aware of the reality of we might see each other and you might know my cousin Bob and Aunt Tilly.
Thank you. We have someone who's asking do you have any tips or suggestions about how to work with colleagues, fellow students, faculty who may not be as inclusive or progressive when thinking about queer issues and healthcare?
Well, I think it depends on, so what I'm curious about is the role or the position or the authority of the person asking the question. I'm not saying you have to tell me, but if you're someone who has the authority to shape policy, then use your authority, use your power to institute mandatory training for everyone, but let that not be a one-off. Like, have this incorporated in every level of policy and procedure so that everyone is having these conversations. Everyone's sexuality is talked about. Everyone's gender identity is talked about. So it's not simply, oh, this small niche group. Everybody's sexuality is talked about. Everybody, because everybody has sexuality, unless you're ace or asexual. And even some asexual people are sexual sometimes. And everybody has a gender identity, even people who are non-binary. Everybody's got a gender identity. So I would say, if you're a person who has a position of power, who can influence policy and procedure in that way, make it happen, because that's your contribution to the struggle to have equality for everyone. If you're someone who doesn't have that power, are you adjacent to people who do have the power? Or can you get a coalition of people to come together to push for or fight for that to be instituted? To me, these never have to be individual struggles, because we're interconnected. And so working with people, I mean, if we look at the national rebellion that's happening on our streets right now, the national rebellion that's been happening since May, this is not one individual. These are people, it's a cross-generational, cross-cultural, cross-multiracial group of people coming together to make changes. And so it can happen, but you're going to have to work with other people.
Thank you. We have a question. What would be an appropriate way to acknowledge a patient's resistance in order to validate it, in hopes that this could ensure a working patient-physician relationship moving forward?
I would just say it. So, hey, you seem really resistant to this. Let's talk about it. I mean, this is what I do in my therapy. I'm like, okay, so you seem really resistant. You seem ambivalent. What's happening? What's going on? What's behind this? Because I want to understand. And if I were a medical provider, what I would say is pretty much what I'm saying now. Help me understand what's getting in the way for you. Help me understand your hesitancy or your resistance. Help me understand, because I want to make sure that I support you in being the healthiest version of yourself. And my concern is that if you don't take this, if you don't do this approach, or whatever it is, you'll have X, Y, and Z. So help me understand. I want to get it. I need to get it, because I'm supposed to be working with you to get you to the healthiest version of yourself. So talk to me.
Thank you. So how can we as providers mention our LGBTQI plus status during patient interactions, especially if we present as, the question says straight passing, I might say assumed to be hetero and cis in a hetero-cis normative world?
Well, some people do something very quiet, and they simply wear a pin, or they wear a couple of pins. So one pin might say, my name is such and such, my pronouns are blank, blank, and blank. And they also might wear another little pin right next to it, or a badge, depending on what country you're from, that says something like they might have like a More Pride flag on, like the flag I have over here, or they might have an intersex flag, or they might have a trans flag or a bi flag. Like, some people wear little pins either on their like the lanyard they wear their ID on. So you can mark yourself without saying something. So, but if you feel like saying something, you could, or you could just keep it simple and just wear a little tag. And so if you're not tag, a pin or pins, patients, patients are curious. And especially if you're talking about pins that are colorful, pins that we don't usually see medical providers wearing, that can open the door to a really amazing conversation or series of conversations.
Thank you.
Pronoun.
So somebody's asking, is there any merit to eliminating a checkbox system for gender identity on intake forms in favor of a fill in the blank?
Well, I mean, that's a fantastic question. And I think I personally like that, but I'm also a qualitative researcher. I love stories. Give me your story. I think that the boxes, truthfully, they're typically for governmental forms or to do quantitative research. So I would then think about or ask the organization or the clinic to think about, well, who's this form for? What are we going to do with this data? Is the data to be used so that we really understand this person? Or is the data to be used to get a sense of how many of these people that we have? And then make decisions based on that. So I personally like the idea of filling the blank, and actually on my intake form for my clients, I have gender identity, fill in the blank, ethno-racial identity, fill in the blank. The only thing I do check boxes for is relationship status.
Okay, thank you. I'm going to try to paraphrase and combine a couple of questions here. A student is asking about being passionate about taking part in social justice, peaceful protests, and this idea that professionalism in medicine means that as a provider, we're quote unquote supposed to be neutral. And then another person's asking, how do we speak up and stand up for people when doing that is seen as a threat?
Oof. Okay, so I'm a social worker and I was raised, you don't ask two questions at once because the first one will get ignored, the second one will barely be remembered. So Dr. Michael, I'm going to ask you to I'm going to parse them apart because to me they're similar, but they're separate. So I'm going to go with, luckily I remember the first one because it's about supposed objectivity. Objectivity is a lie, by and large, because even the system that we work in, it's infused with certain values. And that's just the truth. It's very difficult to really be objective because if you just think about it, whether it's the medical profession, the behavioral health field, they're all infused by Western culture, which is not objective. Culture is not objective. Culture is subjective. And so this idea that one, in order to be a medical professional, has to be objective, I think if you, not that you can't be objective, but I would say go back to the oath that you took when you when you had the white coat ceremony. It's a beautiful oath. It's absolutely lovely oath. And it actually has room in it for you to, for lack of better wording, be a social justice warrior, because as a medical professional who's standing in protest or standing along the sides of patients or working to change things to improve the world for your patients and yourself, that's the kind of medical professional I want to work with. That's the kind of medical professional I would hire. So that's one question. The second question, give me the second question again, Dr. Michael.
So often those who speak up or stand up are seen as a threat. How do we reshape conversations to support people who are speaking up and telling their truth?
Okay. And so I want to be clear. Are we talking about telling the truth in the classroom, in the clinic, in the hospital? Telling the truth where?
All of the above.
Okay. Well, I'm my mother's child, so I have a level of entitlement. But I'm also 51, so I have a whole nother level of entitlement. Life is too short to suffer fools. And with that said, though, I understand as students, there are certain things you have to just put up with because the system was not meant for radicals. This is not a radical system. It's just not. And I don't mean just the medical field. I mean all of the fields that involve institutions of higher education. They're not radical. And so I think it would be important to remember if you're someone who sees yourself as a social justice warrior, good warriors know life is full of lots of different battles, and you really have to pick and choose your battles. Because at the end of the day, if your goal is to get that degree so that you can then go on to do X, Y, and Z, okay, get that degree to do X, Y, and Z, speak your truth, but you don't have to do it everywhere. I mean, and I'm not trying to be flippant, but you don't have to do it everywhere, but you want to pick and choose where you do it, because your job is also not to teach everybody everything. Your job is to learn, get as much information as you can, and then use it to uplift people and to help people evolve to their best, healthiest selves. I hope that answers the question.
I think it does. And I've got a whole bunch more here, and we're not going to get to everybody. So I think I'm going to say that's all the time we have for today. I want to thank everybody who's joined us, and especially to Dr. Imbasciani and George for their generous support, which made this lecture possible. Also, thank you to Dean Page and Tando for your ongoing leadership in the Larner College of Medicine's pursuit of equity and the training of future physicians better prepared to care for all our patients. Thank you again, everyone. Stay safe and have a wonderful evening.